which is Confusion, Clarity, and Consensus on Infections in Obs and Gynae. Today, we are doing the 29th episodes and we discuss infections of the genital tract in various scenarios. And so are our experts and moderators and panelists who cover the topic comprehensively. So today it is about minutes of infections, genital infections and infertility. So I hand over the mic to Dr. Anju Soni to welcome and introduce everything about the CCC series. I welcome you, ma'am.
Thank you, all of you, for taking out your time and be here, because we thought of starting this series with the vision that everybody is talking about everything else except infections, which are so crucial. So we thought of this series, and till date we are today on 29th episode, and I welcome all of you, my very, very close friend, Dr. Neena, who is known for her her academics, and she is an infertility specialist and also HOD of AIMS New Delhi. And I welcome her and all my dear panelists, Dr. Anuradha, Dr. Chitra, Dr. Jitendra, Dr. Lavleen, and Dr. Suma, Dr. Raju, Dr. Manish, and Dr. Lakshmi. And of course, my beautiful youngster team, Dr. Sini, as well as Dr. Manisha and Dr. Shruti, who have been always there coordinating the whole event. So I welcome all of you and all the people who are seeing this. It's my great pleasure to welcome all of you today, because today we are going to we'll be diving into the critical and often under discussed topic, that is weakness in infections and infertility. And we all know that gynecological infections, while often untreatable, and can have a far-reaching consequences if not promptly and properly managed. And these infections can disrupt delicate reproductive environment, leading to complications that may result in infertility, a devastating outcome for many individuals and couples who dream of starting or expanding their families. Understanding these infections and pathways they take to cause infertility is very, very crucial for both prevention as well as treatment. The theme of today's discussion is built around real-world case vignettes that will highlight the multifaceted nature of gynecological infections, and these cases will also provide us with the platform to explore not only the clinical presentations and challenges in diagnosis, but also the latest treatment protocols, preventive strategy, and that can mitigate the risk. We are incredibly honored, as I have already said, with all the experts from all over the country to be sharing their um, extreme knowledge and expertise which they are using in day-to-day practice. So I thank you, all of you. And without wasting any time, I would like to go further to start the program. Over to you, dear.
Thank you, Dr. Soni. It's indeed a pleasure. And I think on a busy Wednesday afternoon when all of us are kind of winding OPDs or coming out of our clinics, it's so nice to see that you all have joined this great program. So I think I will just not go further, but I know Dr. Anju's interest was essentially in infections. This is on a, can you see these, the slide of mine? Can you see them?
Yes, ma'am.
So I know when it comes to infection and fertility, for me, I think nothing but tuberculosis comes. So I thought I was very particular to ask, am I got the permission to go ahead? And I got the go ahead from Dr. Anju or talk infections. I think I'm very happy to have a brilliant galaxy of stars from all parts of India, right from Chandigarh to Kerala to where, I think everybody's there from Odisha, South. So I hope I've not missed anybody's name. And the panelist is very brilliant and vibrant. And before I really start, I just thought I will just tell you that tuberculosis is ubiquitous. It's not an infection of India, but I think the entire world. Though the number of cases of tuberculosis, if you look at the previous, estimated prevalence which came from this WHO portal in 2016, and then subsequently 18, we had the numbers or more. So it has definitely fallen. But still, if you look at it, of the 10.5 million cases that have been reported, 27, almost 1/3 of it is coming from our country. So we certainly say that this is something it's going to be important for the global estimates. And still, if you look at it, India, Pakistan, our color coding, on the number of cases, we are still very high. So this is what I thought I would want, because in these cases, you look, it's they've covered. The previous one was on the number of women and men. And it's a high number here. So basically, tuberculosis infection, which is a common cause of infertility in developing world, particularly in India, you compare with Australia and very developed countries. And I just want to tell that this is an infection hiding somewhere in the lungs or the lymph nodes or bones and joints, and it is definitely spreading to the women's, pelvic organs, spreading from the tubes, which are commonly present, the most common site, and we see pathology to endometrium, and of course, even in the ovary. Of course, these are some of the reasons why women become infertile if they have tuberculosis, right from tubal blocks to endometrium, which bears the blunt, to even ovarian reserves. And I won't give you data and information because it's all on the internet. And also because of the endometrial damage. So I just thought that I would move quickly to tell that there are some of the methods that we are using to diagnose on endometrial samples, doing their tubal patency, doing ultrasounds. And in the case vignettes, we will discuss all of them. So moving further, I think this is the first case which we have is a 34-year-old lady. She's married for 12 years, long-standing infertility. She had a tubercular infection in her youth, in her early years, for which she had taken, I would not use, rather in her late, 20s. That she had taken ATT 4 months back. So we had a clear-cut history that she had taken a complete course of ATT. And this is a lady this is a little earlier case. I can't say it's recent. What should be her workup? We've known this history is there. So all experts, I think all of you are doing infertility, all of you are treating and getting your patients to have IVF. What would be your take on this patient? Would you jump straight to do an IVF, or you think you can treat her, or you want to investigate her further? Anybody from the house, I think anybody can speak aloud.
Good evening, ma'am. I'm Dr. Anuradha. Ma'am, I feel we should go for at least hysteroscopy, see the cavity, and go for TB-PCR or test to see like any activity is there or not, and then we should go ahead for the treatment.
So you would just like to do only a hysteroscopy or anything else?
TB-PCR, endometrial curatives for the TB-PCR, endometrial biopsy, we should send.
But she's completed her ATT 9 months back, and even if you do a TB-PCR, it will still show you positive DNA because DNA may still be present. Doesn't need more management.
Actually, an ultrasound will definitely help you, ma'am. First of all, the first thing, anyway, the patient is have history of tuberculous endometritis. So our major focus is 12 years of infertility and 34 years. We want to go for fertility in a little fast pace. So most probable scenario will be moving for ART treatment. So the major worry for me will be the endometrium. So my concern will be checking the endometrium whether the persistence of disease is still there. So first and foremost will be non-invasive test like an ultrasound, maybe a 3D ultrasound, to see how healthy the endometrial lining and will it is growing well. So these three things to be looked. And if I have a doubt, definitely I will go for a hysteroscopy and probably a biopsy to rule out active lesion.
And you don't want to put in a scope first, you want to do a scan first. How many things scan is needed, or you want to go in for a hysteroscope first?
It's very important to do a scan, ma'am. To check for hydrosalpinges, to check for the ovarian reserve. Then we need to check for additional mobility. We can access everything. What is her enteral follicle count? Then check for hydrosalpinges, check for the endometrium, then Doppler to check for subendometrial vascularity. All these, especially with tuberculous endometritis, these are all very important. So and the other routine.
Ovarian reserve also, ma'am. Ovarian reserve.
Yeah, ovarian reserve.
Yes.
I think all agree that we should scan it first because we get so much more information. And what phase of the time of the of a menstrual cycle would you like to do it? And what all things that you would? You already told reserve, you told hydrosalpinge, you've seen the endometrium, you've seen the pattern, you've seen the flow. So any particular phase where you can do it?
For the ovarian reserve,
follicle phase, ma'am. Day 2 or day 3.
Day 2. Menstrual.
We do just one scan because the world is moving to one-stop scanning, one-stop ultrasound, which gives me everything on just
It-
not the anatomy
You
functionality.
can probably do it just before ovulation, ma'am. We can even check the
Yeah.
flow, the triple line pattern, subendometrial flow. We can also just see the perifollicular flow. And
Yeah.
we can also assess the antral follicle count.
We can see the endometrial highest thickness around 12-13 days.
Yeah, so I would say I would rather refrain doing from the follicular phase because I don't get the functionality of the endometrium. And I know here the endometrium child, if I call on a follicular phase, what information do I get on the endometrium? Very little, A, B. If I call her a little later, maybe in the earlier luteal phase, I get much more information, not only the endometrium, a corpus luteum, which could have happened. Only thing is my AFC will be one less or two less because there's one which is used. But more than that, I get so much information on the on her tubes because you may be able to pick up subtle silent hydrosalpinges, never in a follicular phase, only in a luteal phase. So I think
early luteal phase.
on the side. So how many people agree for a follicular? How many for a luteal? How many for?
I will go for early
Follicular
luteal
phase. Yeah.
luteal phase.
So this woman will definitely not benefit with a follicular because you get no information on her endometrial, subendometrial blood flows. You get very little information on the hydrosalpinges because if you were to do one stop, I think early luteal or
Early luteal phase.
that would be a better phase. Anyway, so ultrasound is what everybody agrees. That's one thing. Thank you so much for agreeing. Now, the next question was, I'll just share you why, because we did an ultrasound, but then this lady popped down with something interesting. And this is what she came. She had an HSD, which was already done. We didn't do it. We did an ultrasound. And before we really wanted to do a hysteroscopy or a laparoscopy, and I'll share you what she showed us. This was the image she showed us in HSG.
So
Bilateral
those
hydrosalpinges.
bilateral hydrosalpinges, ma'am. So before going for any treatment, it should be clipped. It's a bigger size.
Now, would the person who's jumped and said hysteroscopy, would you like to sort of say hysteroscopy would be beneficial for her, or maybe a laparoscopy?
Maybe less treatment. We should go for laparoscopy and hysteroscopy both.
Yes, so she needs. And I think in this time, would say we had done her endometrial evaluation again because we had done a scan for her, but we also did an EA. Now, do you think EA should be done for her or not? Because she's already taken ATT.
Endometrial aspirate PCR, majority of the time we will get false positive. So, because it just shows that the tubercular DNA is there, that's all. So it doesn't show an active infection. But my question is, since the patient has already had a demonstrable hydrosalpinges, it should have been available in ultrasound, isn't it?
No, look, the thing is, she came to us. She had already done an HSG done not by us, but from a facility. Like she came from a periphery. They had ordered an HSG, thinking like a routine evaluation, what most people would do. So we was very happy that this HSG was showing such.
Yeah,
so I've kept this HSG for my postgraduate exams actually. So this was an HSG, and I think we need not have to take any efforts. We went ahead and just put in a scope in the pelvis and also a scope into the uterus, and therefore we did a hydro. I'm sure everybody agrees that with this finding, she would definitely need an IVF. Am I right?
Yes, ma'am.
Yes, ma'am. Yes.
So she had a laparoscopic salpingectomy, or you can do clipping. We did a salpingectomy prior to IVF. Now, big question is, when such a patient comes, you know that her DNA was, if you said the PCR was positive, should you give her ATT or not? Because
usually it is not required.
Because already she has taken madam once. So I don't feel only TB-PCR positive unless we will give for again second time. I don't feel so.
Yeah.
I think, ma'am, we should have, once you do a laparoscopy, if you have a positive washing or any radiological or laparoscopic findings suggestive of tuberculosis with a previous history of positivity, I think it's better to give ATT. That's maybe an indication for starting ATT. Not just the mycobacterial seen on.
If patient has not taken any medicine before that ATT has not taken, then if any positive finding we should give.
Even after taking ATT, if you get nodules or if you get tuberculomas, then I think you need to send for culture because that may be a case of resistant ATT.
Yeah, the test required is culture or gene expert and other tests, definitely not PCR.
Thank you so much for bringing this out, that we need to do some tests. But if you look at it, gene expert is a glorified,
No, it's only culture positivity.
There's a lot of controversy on gene expert also.
Gene expert. So I think a good idea would be to look at your, as Raju and Manish have already pointed out, not just to look at her, DNA, PCR, or genetics, but look at the hysteroscopic findings and the laparoscopy. If there's something more sinister, and I'll take you through other cases, and I will tell you, I think that makes a merit a ground to do ATT rather than just giving, because DNA will still be picked up from dead bacilli because they will still be showing. Thank you so much. I think all of us are on the same. I just want to show here a diagram that how the paucibacillary infection it is, and these are present there despite the fact that they grow slowly and may not be picked up on routine cultures and routine endometrial aspirations. But I just want to share out some kind of data which comes from literature, in which there are studies, which is one randomized trial, not very recent but still in 2016, which they published in an RCT and said that there was no benefit of giving ATT on the premise of a positive PCR between the two groups they gave, and they found there was no benefit. And then this was the entire study. And then there is another paper, which is again very older, but it comes from Dr. Jindal. It was published in Human Reproduction, where they did give to all the PCR positive, and they found that the median time to pregnancy reduces. However, this is much older, but I think in today's day, but they never, both of these studies never utilized laparoscopy to complement. And we'll take you through more data as we go to another case. So I think a lot of knowledge has been added to all the viewers who have been there. So let's move on to another case. So she's a 28-year-old from an upper middle class. She was a lawyer, I remember, with primary infertility of 4 years. Her routine, I've not got the routine. By routine, I mean a basic, investigation, the husband semen analysis, an X-ray chest, as we preliminary do. A lot of us do, in our government setups, their routine. Montooks I don't do anymore, but any of the routine investigation were normal. So her endometrial aspiration was negative for a granuloma or for an AFB or for a culture. Even a DNA PCR was negative. But an HSG one was done subsequently, because she's infertile, and we saw that she had cornwall block. So I just want to ask all of you, this is not an unusual scenario, People will question me endometrial aspiration in all cases. We do not to check ovulation, but in a public hospital, we do EAs to screen women for tuberculosis. My clientele is still very, very low socioeconomic. So we still have a SOP where we're doing, irrespective of what they are, an EA to subject them to even HSG. Because if there is a silent tuberculosis thing, it could blow up my disseminate infection through an HSG. But her HSG shows a corneal block. So what do you think you plan for her? What is your next plan?
My plan for a hysterolaparoscopy.
Laparoscopy, because it can be because of corneal spasm also, ma'am. Corneal block. So it's better we can
Should be confirmed.
Yes, I think that's the way we did. Absolutely. So we went for laparoscopy and proceed. So this was a laparoscopic finding. This is what you can see, adhesions. And there was findings that there were even subhepatic adhesions, and there was even adhesions with the periovarian membrane. And this is like a lawyer, educated girl, and she was like, when we gave her these findings, she was very surprised. So now what do we think for her? Do you think she could be infection, or she could be tuberculosis, or she would
otherwise? Hers should be taken, and we should think of tuberculosis, ma'am, because these adhesions are there, and
I have a different opinion, because especially in my part, Kerala, the tuberculosis incidence is very low. Suppose such a patient comes to my obviously I make the diagnosis for PID, most probably chlamydia, and put her on some antibiotics. Very honestly, I may not do any peritoneal washing or anything, because the probability of seeing a tuberculosis in our part of the world is negligible.
But then, Raju, would you like to comment? I know the peri-ovarian adhesions or the ones in the pouch could, but what about her adhesions with the omentum?
Yeah, true, ma'am. I think
chlamydia could range to, subhepatic, I agree. But the kind of, I was showing you into the omentum and the parietes, the ones which are really going, do you think you would
because if the adhesions are definitely suggestive of PID, but to pinpoint it is due to tuberculosis as a cause, obviously we need to have a confirmatory diagnosis. So how to get that confirmation? Obviously, this peritoneal washing for the POD will definitely give an edge. But with these two findings, laparoscopy is suggestive of a PID, along with some test to convince. If these two things comes as positive, obviously we may have to consider tuberculosis.
How would you confirm your chlamydia positivity?
Perihepatic adhesions are also visible, ma'am, in the right.
Those can also come from chlamydial infection. Fitzhugh-Curtis comes through a lot of other
So how do you sort of rule out then?
That's
How would you rule out a clinical infection?
We sent that cultures for
And media
testing.
endometrial curatings also can be sent, ma'am.
Yeah,
For
true.
this.
Yeah.
Endometrial also can be sent for this backtech for the gene expert.
Yeah.
Ma'am, we had one case where the patient did not have any symptoms, only one momental adhesion was there, which is attached to the bowel. I think so, a little bit of granules over the surface of uterus. When we sent that, came positive for the tuberculosis, ma'am. So I think so with all these findings.
So what we did, we just with these findings, we sent for peritoneal washings, and this came out as a positive PCR from the DNA was positive mycobacterium tuberculosis. So I think we did not get anything but the bactec was negative from the washing, but the PCR was positive, and therefore we had a reason. So would you start ATT on these findings?
Yes, ma'am. Yes, ma'am.
Better to start it.
Yeah. So all agree. So we
Yes.
start on ATT.
Can we have a hysteroscopy finding with this?
The
Yes.
hysteroscopy was absolutely normal. There was no finding in hysteroscopy at all.
If
Hysteroscopy was
hysteroscopy shows signs of endometritis, then it is more of a tubercular rather than chlamydia.
yes.
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 Actually, these are
If it is
cases
a
that
thin endometrium, then it is a more of tubercular than chlamydia. So we can take some conclusion. We don't have any regular test for this. Many times, even if it is tubercular, the washings will come out to be negative.
yes, I think Dr. Manish has pointed out something very nice. These are cases that I picked up from our very multi-centered project we had from ICMR when we were regularly that part of the protocol. I think I have a slide, or I don't have in this case, Vignets. We had a SOP in which all the patients who were EA positives, endometrial aspiration positive on whether gene expert or PCR, we had to scope them. So we consented women only, and we had taken women who had not taken ATT in the past, who did not have tuberculosis.
Yes.
So some of these patients are from that group. And I would share you very interesting finding. I'm talking of this finding maybe around 5-6 years back when we concluded, and we saw our hysteroscopic findings. Very interestingly, those who had positive PCRs, either on the pouch of Douglas, had very typical findings of endometritis, and we had done a lot of their, CD 138 and other markers also. Interestingly, they came very high. We couldn't really explain at that time, but we had those typical findings, what you see of classical endometritis. And we realized that tuberculosis has got some kind, which, maybe Italians are reporting and giving us stories of, endometritis findings. I think as Indians, we have a good record. I think we should publish that data on hysteroscopic findings of early tuberculosis, which may not come positive. I think Dr. Manish has rightly pointed out that, these are some patients where, endometrium would not give you any positivity on thing, but the typical, blebs that you see, or those, starry looking angry endometrium, these are some pointers. And despite even open tubes, that's something. So thank you so much for getting this. So she started on ATT, and the good news is this patient conceived right even on ATT only. She had a pregnancy. Just want to share that you do get surprises like this. Okay. So let's move on to another patient. She's a 32-year-old with infertility for 6 years. And she had absolutely normal semen analysis. The tubes were patent, and therefore she had already taken 6 cycles of ovulation induction and intrauterine insemination. And when she came to us, we just, because as a part of protocol, we just kind of work her up. We did our EA, because this was the part in our hospital, and everything was negative. So she looked to us as an unexplained infertility, and a DNA PCR was also negative. So we went in for a laparohysteroscopy. Those days we were really doing before we jump into, and I will share you some of the findings. Can you see those images on the hysteroscope? Some features, yeah, there's some features of inflammation, and some features also of endometritis. So the pelvis was absolutely normal. The hysteroscopy did show features of endometritis. There was absolutely a normal clean pelvis. And as we turned around, there's this perihepatic. So again, Raju, I'm sure if she's Kerala, you will not say for tuberculosis, will you?
Well, very honestly, it's a bit shocked to me. First of all, if such a patient comes at the present scenario, we may not even do a laparoscopy. We most probably straight away go for IVF. But finding this, my first thought will be obviously it's PID. But very honestly, when tuberculosis will not come to my mind because we hardly see it.
Yeah.
Same here.
So the geographical distribution, I think Chitramada can also put a thought because
Yes. We have seen a case of PIDs more than tuberculosis. We have sent so
Yeah.
many for EB pathology also, and even gene expert also. Most of the time when you have high suspicion, it's coming as negative.
Negative, true.
So we had sent her PCR because this is again, now it's the protocol. So when we get nothing, we do send the peritoneal washing, and she was positive. The PCR was positive. So I just want to tell you that you do get surprises, and when you're in doubt, I think in infections, when you don't have even the gene expert, maybe we do get patients who, and we are actually finding should we give them ATT or not. I think this is the only way. Otherwise, even if the PCR on the pouch of Douglas is not, I will also not give her ATT. Probably give her an extended course of doxycycline. So I would just, again, I want to ask you people, when you are sending your patients for HSG, this is a thought a lot of my postgraduate asked me, when you do an HSG, do you advise routine antibiotics? Yes or no?
Yes, ma'am.
Definitely.
What antibiotic would you cover?
Doxycycline and metronidazole.
So if you're giving doxy and tinidazole, do you think it's covering chlamydia, yes or not?
No.
No.
Usually we give
Azithromycin for chlamydia, we have to give usually azithromycin.
So yes, so if you're giving doxy as a routine, doxy may not, but yes, to completely cover chlamydia, you need to give them a course. So there's a kind of debate I ask when patients come out from outside to us from treated by for an HSG, got antibiotics. I also keep a thought: has it not covered chlamydia good enough?
Ma'am, rather than giving doxycycline, we should give minocycline. That will have broader coverage.
Okay, so I think this is another good point to learn that we should give. So I just want to say, why do we do actually laparoscopy in these cases, and what is the reason why laparoscopy is added? Because of course, laparoscopy, you do check tubal status in doubt cases like you had a corneal block or you had a clear-cut hydrosalpinges, which is actually operative laparoscopy, but actually it gives you an idea of the peritoneal status. And also we know that we can take peritoneal washings or at times even biopsies, as Dr. Manish very pointedly said. In fact, there is data which is coming from older retrospective data and also from Dr. Jindal's work, who published a lot to tell that laparoscopic findings are really useful because in up to 33 to 60%, they could make a diagnosis only on laparoscopy. And also laparoscopic findings, if you look at HSG to diagnose the diagnosis was 59% diagnosis coming as contrast to just 7.9. I just thought that I will show you that this is kind of an algorithm we find because we do see tuberculosis still in our part of the world. We do get a lot of patients from Bihar, we get from UP, and therefore this is the way. There's a classification which was given by Dr. Deep Thakkar, one of our ex-HODs, and then this is accepted even in the ICMR trial, and some definitive findings to probable, possible, and incidental. So if you have tuberculosis causation, definite, probable if these are findings which could, and possible if they are flimsy adhesions, dilated tubes. And obviously, if there are possible findings, we won't jump to give them ATT. But yes, if you combine them with hysteroscopic finding, as you all agree, then I think it makes grounds to give somebody ATT, even in the absence, because we feel that this could be covering infections, early infections in the endometrium. So, and again, I will share that we've published from a lot of data. This was in the Journal of Minimally Invasive, the AAGL journal, where we published the role of laparoscopy in the diagnosis of genital tuberculosis in an era of molecular tests like gene experts, and where we found that only 2% of our conventional tests were positive. We found that laparoscopic findings improved or increased stepped up the diagnosis. And of course, there was a kappa increment of 0.25 between PCR and laparoscopy. So this is kind of a good, as a statistician say. So as a standalone, PCR is not a good test for diagnosing and also justifying. So I would say don't jump to give ATT. I'm sure you all will. And when you do a laparohisto, it actually improves your diagnostic yield of a genital tuberculosis. Of course, if you have a suspicion, this is a message from a lot, not you people, you are all experts, but in the periphery, that people don't have access to laparohisto. I think it's a good idea to refer to your colleague, and therefore infections, particularly tuberculosis or chlamydia, can also. And I think very rightly, Dr. Raju, and those who are practicing in the South who don't get to see, I think somewhere the nature of adhesions also helps. What do you people think? How do you comment on the adhesion that you get from tuberculosis or from chlamydia? Any opinions?
Bad adhesions, madam. Yes. In our side, it's very bad adhesion for tuberculosis.
Yeah. So I think
very dense adhesions, and usually the appearance of the tube, which is the femoral end, the terminal end, which is more involved,
rather than the, and they sometimes the fibrosis and the tubes are not pliable. All those things also give you an idea that this is more likely to be tuberculosis rather than any other infection.
Yeah, I think Lavleen has really touched the right point. Don't just look at the lesions, go deep, look at the tubes, look at the behavior of the fimbria, their agglutination. Though agglutination could point to chlamydia, but the fibrosis between the tubercular and a finding would be more helpful. Okay, so let's come to the fourth case.
Ma'am, when there will be TB-PCR for atypical bacteria, the report comes like it is positive for atypical bacteria. So what is your take-home message?
On atypical bacteria, again, I would say mort as a mycobacterium other than tuberculosis. You often get mort also. But on mort, when you go to the guidelines, actually there is no way that you are justifying yourself. But yeah, there are colleagues of mine who give empirical ATT, but how good it is to give somebody another 6 months course is a very debatable issue. I won't be able to comment on that.
We had discussion on tuberculosis through the NOVA people, and Dr. Sonia Malik was there, and a lot of experts from PGI, from the medicine department also. So they pointed out that mort is not to be treated with ATT. If you get mort, you are to ask the lab to do an extended culture and give you a sensitivity of specific antibiotics, which will be not ATT.
Because maximum time we get normal bacteria negative, but positive TB-PCR positive for atypical bacteria. So now there is confusion how to go ahead.
Okay, we have another one which is again a similar story. Yeah, please. Anybody?
Ma'am, I have one doubt, ma'am. Do we have to do Monto for all the patients of infantile?
We have to do
Monto test. Monto.
I tell you, Montux is what thing which I really don't know. IGRA, Montux. In fact, we do Montux. We stopped doing it. But if you look at the alert which came from the WHO way back in 2013 or 14, clearly says that IGRAs are of no value in developing countries like India, where people are actually getting immunized for tuberculosis. So if we do at Montux, the story is same. So I think IGRA or Montux.
Definitely not for everyone, but where you are really in doubt, then you may get a very strongly positive. Say if you get an induration of about 20 mm, then it is expected to be not because of the vaccination. So it's only an unusual case where you are really in a diagnostic dilemma whether to start or not. Otherwise, routinely, I don't think there is any sense in doing Mantux for everyone, because we are all vaccinated and we are expected to have a positive.
But then the question is, do we start ATT on the basis of an IGRA or a Montux?
Yeah.
No, depending only on Montux.
I think it is more like the PCR. If you have evidence in some other form, then maybe, it is not on its own. You cannot start on the basis of IGRA or Mantux. I haven't done IGRA in all my gynae practice in all these years. Mantux very rarely, very occasionally when you are really in doubt. Especially say if you have a treated case and you are in doubt for whatever reason. So then what do you do? Okay, let's see if it's a strongly positive Mantux, then maybe yes.
Okay. So we'll move quickly. We have just 20 minutes now. So this is again a typical case. I would just ask, if you saw distal hydrosalpinges with free spill with 5 cycles, what would you do? I think I will offer an IVF straight to her. What was the comment of others?
Yeah, ma'am. Already she has undergone 7 cycles of ovulation next. Distal hydrosalpinx, yes, ma'am.
Yeah, I think anybody differs.
The distal hydrosalpinx, you have to see either any collection like communicating with the cavity or not. If it is communicating before going for IVF transfer, we have to clip or take it out. Salpingectomy we have to do. Yeah. And no doubt we have to go for IVF.
Yeah, so this was her tube and they were the distal hydrosalpinges. Yeah. And again, I thought we'll just say we will share you because these are images. Oh, wow. See, because you do confuse them. These kind of findings sometime with chlamydia, since the story of infection and chlamydia is there. I just thought we had to use our bipolar forceps is reaching out. And of course, the plan is that you do ATT or not before IVF is a debate here. Again, hysteroscopy here was normal. So I just wanted to ask people, because a lot of time patients come, they've taken so many courses of ATT, and I just wanted to hear from you people that once people have taken, do you believe in giving ATT or not? That's the whole story here.
No, not at all.
Don't repeat it again before IVF because they have already taken.
I won't give. I feel.
Yeah. So we'll just go to another interesting case, who's a case of, again, scanty periods. She had taken it. In fact, I thought I wouldn't have time, but I'll share you some of our experiences, because now we have an ongoing projects, 2 projects that we've had. We've ongoing one and completing the other. So scanty periods, of course, when there's scanty periods in a ATT past, there will be an involvement of the endometrium. So she has an AMH of 2.6. A baseline scan shows a good, AFC is nice for 32 around 12, but her endometrium was always thin.
Then we have to increase the endometrial thickness
It
by
never went
adjuvants.
beyond 4.4. It was over
Yeah. Scanty periods means first thing is
The most difficult
tuberculosis
case.
syndrome.
Yes. So thank you so much. I think the diagnosis is very evident. This is basically even the estrogen priming that we gave her, whatever, we never went beyond 4.2 millimeters for her, typically often. So again, since this is, and this woman would definitely need with an IVF because of the tubal factor, involvement of the endometrium. What needs to be done? What is the prognosis? And simply, what do you think is the option for her when we talk of a thin endometrium? What are your thoughts?
So whatever we do for thin endometrium, everything is only adjuvant treatments, which may work or may not work. So we try all things like ecosprin, then sildenafil, then estrogen, then colony stimulating factors, finally like PRP stem cells. These are all the options that we have for treatments. But before that, we do the ultrasound assessment for everything.
Yeah. So you rightly said, Lakshmi, whatever we do, things don't work, but obviously you can prognosticate some. As I said, this woman's volume, endometrial volume, and even the
volume is the most important thing.
I think before we really spell her a prognosis, we think we should spend a little time in doing her imaging, measuring the volume, looking at subendometrial flows. And I think this does help to give a prognosis. So these are
in such a patient where once again there is no evidence, even if you do many times these kind of patients come, you do an endometrial biopsy, you do not get anything positive for tuberculosis. So is there a role for somewhere deciding for ATT in these kind of patients?
Unless everything tells, then we can think of.
I'll just tell you, by the time the endometrium becomes thin and scarred, the damage is already done. To give her any kind of ATT will not work, because those tissues, because what is the whole idea? Because if she got ATT, though she's got 5 years back, we don't know whether she took it, because we also know that the DOTS program did more harm to these girls than, because the compliance was there, but were they really getting that daily versus the twice a week dose? We really don't know about that. So I don't know, I'm a little apprehensive on that. But my understanding is once that they have two group of women whom I really feel ATT may not happen, when they have got taken ATT, those beaded bad tubes, and when the endometrium has already gone away, especially from tuberculosis, then even you will get PCR negatives, there's no point. Unless and until she's got a recurrence of a growth, which will definitely be picked up by some of the tests, I really don't see any virtue of giving, because the harm, the vascular damage has already happened. So you really
fertility
don't.
Wise, you won't gain.
Yes, yes. So these are some of the features which can actually indicate us, like presence of fluid in the cavity, those calcifications. These are some pictures from our own, ultrasound machines that we keep storing on patients. You can see, I mean, that if you put in a hysteroscope, what do you get? Some kind of atrophic. So these are some of the findings on a 3D, 4D, that you see of the endometrium with, subendometrial calcifications. And these are some of the pictures that you see. And also the day 21 that you got, very typical, I see a lot of time a T-shaped cavities, on the 3D. And this is something again which makes me suspicious. And when you go in for a scope, you realize, yes, the endometrium are very patchy. They may not be pale atrophic all through, but there are some features which do point to these kind of pictures. So, these are some of the pictures of the adhesionolysis that I just want to show that these are all images from the same, as I said, when we were doing the ICMR trial, we have a kind of a library of hysteroscopic findings, right from normal to, all the variants that I want to show. So moving on quickly. So as Lakshmi already pointed, we do give them sildenafil aspirin, but in these cases, we really do not get any this thing. So any experience, anybody giving them PRP, stem cells, Any idea anybody has given?
I do routinely, madam, hysteroscopic guided with the oocyte needle. I used to put just sub-endometrium. It is working. It is working.
Okay. It is working. Now, one thing I want to catch, is it working in any thin endometrium or an endometrium of tuberculosis? That's what I want to ask.
No, ma'am. It is not endometrium of tuberculosis. It is a thin endometrium.
Yes.
So, I have some experience sharing to do. When we tried doing this subendometrial injection in during hysteroscopy, I never had that satisfaction because I could see it coming out. That yellowish fluid will spill out, and how much of it would get washed away with the hysteroscopic fluid, I was never very convinced about it. So, what we started doing was we would just put in a pipelle, a little disturbance of the endometrium, a little vacuum, and with that disturbed endometrium, we started putting in PRP. I don't say it worked in 100% cases, but it seems to work much better than just putting PRP. So in the cycle, 1 or 2 cycles before the embryo transfer in our IVF patients, if we have a persistently thin endometrium, we found a better result than just putting in PRP intrauterine during the cycle of ET.
Okay. So
how you put how you are putting?
Lakshmi wants to speak something. So I will share you our experiences, and we are presenting it as a paper in ASRM. So you know what? I am doing PRP is not in tuberculars, because you know what? My ethics committee had given me approval to go with thin endometrium, which is 5 millimeters and less. And these were they were all thin endometriums in women waiting for frozen embryo, or also those who had had a missed abortion DNC. So of the 50 patients that we had, we did all hysteroscopic. And I would share my experience that our PRP is not prepared in my lab. It is prepared in the blood bank. And I've also presented this work in my lecture in IFS, and I'm going to present again in Fusion on PRP. And our technique is freezing and thawing. The thing is that what is the reason why endometrium should improve in a thin endometrium is the release of granules from the platelet. So it's platelet-rich plasma. And therefore, some kind of activation has to happen in the platelet. So either it's a chemical or a mechanical. And when we reviewed the literature, my colleagues from the blood bank and the hematology felt freezing and thawing was a very good method, because you're not adding, because there are a lot of chemicals that have been suggested, chromium and some kind of compounds, either the whole series on animal models. And we found that what we do is we take the sample, freeze it in small aliquots, and we thaw it just a couple of hours before the procedure. As pointed out by one of you that you're doing hysteroscopic, I do hysteroscopic guided subendometrial injections. And I'm talking about my first case when I did in 2021 or 22, when I had just got the ethics approval from the stem cell committee. The first patient of mine was a daughter of a doctor, herself a doctor. The mother's, I won't name, mother was a dean of a very prestigious medical college. Endometrium didn't move beyond 2.83. And she had a miscarriage after an ovulation induction. And I just said, look, in the realms of science, I don't have experience, I'm putting it. We put in one PRP, and when I entered the cavity was atrophic. There were hardly anything but flimsy adhesions. And after the PRP, we found an improvement of moving to 4.2, 4.6. We went in and did a second PRP, and she conceived spontaneously. Getting the encouragement 2022, and these are cases which we presented even in some of the forums. And then we had 2 of our sisters waiting for an FET, conceiving naturally. The embryos are still lying with us. So from this 50 patients that we had from the ethics, we found that this is non-tubercular, mind you. I have not tried it in any tubercular patients. Out of the 50 patients, 32 showed an improvement in their linings. We did it initially in the phase 1 cycle before the FET cycles. So there was definite improvement in not only the thickness, but also the flows, and also the ones that we got pregnancies, 17 were pregnant. So if I look from the 50, 17 pregnancies, but from the 32, definitely 17 is almost 44 or 46% pregnancies. And we are presenting this in the recent ASRM, it has been accepted. So I just want to say it is the technique which matters of activating the platelet granules, because a lot of people did not agree with me that we are using fresh. It should be.
And what I used to do, I just prepared the PRP and put in the liquid nitrogen for 15 to 20 seconds, and then take it out again, rub for 2 minutes, then again put it. Like this, I used to do for 2 to 3 times, 3 times usually. And when I put it, I have seen very good results, ma'am. Like if it is less than 5, 4.2, 4.5, and the next cycle after PRP, I used to get 7.8, 8, 9 even. It's very good results.
So
But
our blood bank people said that when you freeze and thaw, then there is that freezing thawing releases, it is a mechanical method. So you don't have to add any of the additives that will, because people who say we prepare it in our own lab and then, well, there were a lot of, apprehensions. My team, my researchers and collaborators did not agree. They said, how can you use it? If you're using a fresh, you have to activate the granules. Without activation, you can't. Because the purpose is to increase the level of growth factors. So again, I've done an intensive review of literature. Intrauterine also works, but my thought was if you're putting intrauterine, how much long will it last? Because the growth factors, if you go to the whole, if you read the genesis of a thin endometrium, those growth factors have to potentiate the progenitors, which are the cells in the subendometrial layer. So that was a thought. And therefore, I will just share you another experience that we have another trial from the ICMR in which we are looking at women with Asherman syndrome. And we have 3 arms. One arm is subendometrial PRP, the other arm is subendometrial stem cells, and the third arm is a combination, that means stem cells and PRP. Because in mouse models, we read that the both stem cells and PRP work by different mechanisms. So the PRP act by releasing the granules, whereas the stem cells are the progenitors, which will actually go into the subendometrium and work on the different pathways to activate the cells. But in mouse models, there are some studies which say that they both are synergistic. So we have got this money to do this pilot work, and we're using a simple Jamshedi is needed. So we have again our hematology team who draw out those bone marrow, and then we process it and centrifuge it, and when we instill again, that is prepared fresh. And in the third arm, where we're using a combination, we're using 1 ml, 0.5 ml but definitely we're using again the plasma, which is frozen thawed from the patient whom we've actually freeze. So these are some of our experiences, and I'm sure since we've got a CTI number.
Ma'am, for freezing and thawing, which media you are using, ma'am?
So we're not using any media. We are just freezing the plasma at -20 stored. So when a patient comes, we are taking her sample, and because we have aliquoted her when she needs for 2 to 3 times, the same other aliquot is removed and thawed. So it's not a media. It is stored at -20. And this is what I could even share the whole process of,
making that would be better.
Drawing out a plasma. The whole protocol is, in fact, we will be, we are wanting to publish this paper of ours, because when you get a CTRI, then you have got more, confidence, because any journal would want you, it's ethically approved, you have a CTRI number, those things make it. But for the stem cell, yes, we had a lot of challenges, because the third arm, which is a combination, we needed a lot of approvals, because this kind of work is yet not done. So that was the only thing which I thought I could share. What we have also added to the ones because this is on Asherman's, we've added a element of measuring the endometrial volume, because we feel very happy with endometrial volumes coming back. And trust me, these are some of their patients, but then they're non-tubercular. I don't want to take any, experiments, because tuberculosis is again an immune-mediated disease. I don't know what immunology is settling there. So as of now, our pilot work is basically on non-tubercular. Maybe while we get the results, we will move further. That is my thought on tuberculosis. But I would just share you some of the work which has been done. These are all autologous platelet-rich treatment, but this is all in refractory, as I said, in refractory endometrium. And as you all shared, that PRPs, which have been put 2 or 3 times from menstrual day 10 of the FET cycle. And this is, in fact, data when we reviewed, you can put in PRP up to 72 hours prior to a FET. However, I generally put in 1 cycle before. And also there is, some publications on use of adipose-derived stem cells also, because people say that adipose-derived stem cells are better. However, we are using, bone marrow-derived stem cells in our trials. So this is again a study which has come from Ukraine, and I think there's some study even from Dr. Nagori's publication is there, who has published his case, but that's not a series. It's not a full. This thing is just 2 or 3 cases. He's presented a short series of cases in which they have done from Dr. Sonal Panchal and Dr. Nagori's. But I just thought I will share you that from Ukraine, they've had 9 healthy babies from 19 women who had adipose-derived stem cells. which were pushed into the endometrium from the patients with thin endometrium. But these are again, mind you, these are again thin. When you read the paper, you'll realize that they are all non-tubercular. So, you all have to really know whether tuberculosis patients really benefit. We really don't know. So again, some papers in Asherman's syndrome. This is a pilot cohort. Again, I picked up. These were bone marrow derived stem cells, and they were the ones which were isolated by and delivered into this is the study which is the work of Carlos Simon, the EV group including Antonio Pellicer. This is one of their papers which was originally published, and I don't know whether anyone would accept it. They were actually doing a uterine artery embolization and then pushing these bone marrow derived. So for me, this was very, very horrendous to actually, embolize a uterine artery, reach up to spiral. So I thought, why not do subendometrial? So this paper was actually the reason for us to put us that work. And they also got 7 pregnancies after 14 embryo transfers. So this is all that I would say. But yes, if there is a conception, we have to be very, very careful. You have to give the prognosis in tubercular patients because successes would really be very low if there is involvement of the endometrium as thin endometrium. So I think I just had these cases. Anybody wants to share any case, I'll be happy to sort of hear from you people, from those who have got any other experience of infection, because Dr. Anju was very particular. I talk of infections, and to me, coming from Delhi, tuberculosis is the #1 infection for me, at least still in my hospital, when it comes to infertility. Dr. Raju, what about you? Let's hear your experience on infections in Kerala.
Madam, in Kerala, I think maybe in my 18 years of service in Kerala, the total number of tuberculosis I've seen may be less than 5.
Okay.
And similarly, I did my fellowship in CMC Vellore. There also we used to do endometrial biopsies for almost all diagnostic hysteroscopy laparoscopies. And there also the incidence of proven tuberculosis is very less. So maybe we are lucky enough to say. And majority of the time,
I'll tell you, I totally agree. I'll just stop you because we had 4 centers, PJ, Chandigarh, us, Lucknow, and Hyderabad. Hyderabad pickup rate was so low that we couldn't expect we are having a collaborator from India. I totally endorse it.
Yeah,
in Hyderabad, it is definitely less, ma'am. Actually, every time we send for MTP gene expert, it comes negative only. So sometimes we feel that we are not able to pick up also. So I wanted to ask, what is your opinion about sending menstrual blood on first day for AFP culture?
There's again a lot of debate while we were putting this grant to the ISMR. We did a lot of review. What we realized, and this is an understanding which came when we talked and discussed with our microbiology colleagues from PJ Chandigarh and AIMS. They say that the tubercle bacilli are basically in the superficial layers. Yeah. By the time it collects, it depends on how she's collecting A, B, menstrual cup or not. C, they said that when you gene expert and your PCR test would be very highly positive. It's only if you have granulomas which are there, because the granulomas in the superficial layer, they're shed off. But again, when they tried to do the histological part, they said picking a granuloma from menstrual blood is very, very difficult. So we realized on the logistics and the understanding that doing menstrual blood may give you very high false positive when you look at molecular tests like PCR, because no matter how good and intelligent a woman is, she's likely to contaminate from her skin. And where will you go? You will definitely pick up many more. So I would never recommend anybody to waste energies and time. And again, how you culture, because if it's contaminated from the skin, you could even grow some of those nuisance stuffs which may cross-react with your skin. So
and the social stigma it creates.
Dr. Nina, you can stop sharing the screen. The discussion would look good.
I just thought there's a last key message that cases may not benefit an ATT. And also, we may be probably looking at some NGS based, because now the world is moving to NGS. Do we have some tests? I don't think researchers have really found any one of those, tests. So I just thought when it's a healed situation, ATT does not kind of really help. Any experiences, any questions, Dr. Manish, your side of the world, if you have experiences? Because South India, I totally agree. From the Hyderabad centers, the story between Delhi and Lucknow had very high cases. PJ are still lesser, but Hyderabad was absolutely 1%, 2%, while we were reporting higher.
No, not much.
Not much.
We do have a lot of cases of tuberculosis, but we are unable to diagnose. And finally, when it doesn't work, we go for a endometrial tracking. And if endometrium is thin, we try all these maneuvers. And ultimately, when we fail, we discuss with the patient. See, this is a kind of treatment. If you are willing and ready to take that risk, then we are there to help you out. It has worked in our patients. I have cases. They are with me and they have worked. Without any reason, IVF has also, by giving just AKT, when the tubes were open, it was like we have undergone, she has undergone one cycle of IVF somewhere with one cycle, myself also, but the endometrium was not growing. The embryos we were unable to transfer. We gave AKT and there are two patients who conceived spontaneously. Ultimately, our aim is to make her conceive. Yes. But it has to be in a patient discussion. The couple has to be discussed. This is a kind of treatment you don't have to be, but it might help you.
Let's hear from Dr. Anju. She has been.
I totally agree.
Let's hear from Jaipur.
I know a lot of gynecologists who are practicing. Any patient of infertility which goes to them, I can't name them, of course. They just put them on antitubercular and they claim that all those patients, many of them conceive. But how ethical it is to give them antitubercular without diagnosing, it is very, very
now it's very difficult to give AKT without
It is not ethically right to give treatment to people.
It's criminal. You'll increase the drug resistance so much. I'd rather very unfair.
There's high side effects, ma'am. Very much.
Yeah.
I'm not comfortable to take.
So you can just,
but lot of people are giving it. When we were having discussion with Dr. Sonia, she clearly said we should not give. It is not ethical. Number one, and number two, very, very important thing which she said about the thing you were discussing about the menstrual PCR. That also is according to the guidelines. No. So we should not send PCR of menstrual blood. So all of those who are watching should take this message that PCR for menstrual blood should not be done, because it's not going to give us the right kind of information. So that is no for that also. And of course, you have discussed very, very crucial point, Dr. Neena, and all the experts from all over the country, that imaging is very important. And before I go further, I would like to give my best wishes to Dr. Neena, and I'm sure you will also give, that she is going for the chairperson imaging committee in Foxy, and I'm sure she'll do a great justice, being a teacher herself. And as we all know that the practice in recent years have completely changed for gynecologists, to shift from sending their ultrasound to the ultrasonologists, then doing it themselves, especially for infertility and other practices. So I think she will train many more people in the country to do their own ultrasound. So Dr. Neena would be a great choice for all of us. So I'm stopping here. But what is very important is that imaging science has definitely changed our practice in recent years. And for infertility patients, we have to first resort to imaging, and proper imaging is very, very essential. And for us, when we are doing the imaging, we understand each and everything, but everything is a part for us. We know how the tubes look, we know how the uterus look, what is the kind of position. So imaging should be the first tool, and then we go to step 2 and step 3. And as she is very rightly pointed about, if you have to do one ultrasound, which phase, I think all the viewers must have taken that point very, very well. And all of you have really done a very, very great discussions, covering almost each and every point of how you are managing your normal patient when the patient comes to your OPD with the history of infertility, how you go about it from basics. It has been discussed. So all of you can give one point before we wrap up, and then Dr. Neena's last point.
My point. don't overdiagnose tuberculosis because this creates a lot of social stigma to the individual and to the society.
And no empirical treatment for ATT for all infertility patients.
I feel only TB PCR positive, we should not give ATT. Along with TB PCR, we should get other findings of laparoscopy or hysteroscopy. Then only we should proceed for the ATT.
For me, I think high degree of suspicion should be there when you find the adhesions, perihepatic adhesions or the peri-ovarian adhesions. And I think some madam has pointed out peritoneal washings is a must to confirm that it can be a tuberculosis or to differentiate from PITs.
You have to be definitely very careful in starting your ATT because an unnecessary ATT is not only harmful to that patient, but to our society at large, where we are creating drug-resistant tuberculosis. And just coming to that for a long, long time now, we do not use quinolones in our practice at all as prophylactic antibiotics, also for the same reason, where we must save those drugs for MDR TB.
Drug resistant.
Correlate with your hysteroscopy and laparoscopy findings. Do not just go on laparoscopy. Correlate with your ultrasound, hysteroscopy, and laparoscopy. And if it is positive, you can take AKT.
I think all of you all have given pearls of wisdom.
Very one important very thing is whenever you're treating these patients, especially for IVF also. So we have to give them a very guarded results, as the second last slide of Dr. Neena said, that in every type, not more than 20% of we will get the results. So that counseling is also very, very essential, because giving a hope to a couple and then their hope is not fulfilled is also another. So we have to kind of make a counseling in a manner that we are giving them a hope, but the hope is not very, very high percentage per se.
Hello?
Yes. So over to you, Neena.
I think everybody's covered it well. I just want to say one word. Thank you so much, because that's the best thing you would have. That's it. Everything covered. And I just have that individualize your patient rather than just see that she's positive. I think all of you have given it. You have to be individualizing your patients. That's
Absolutely.
Thank you so much. Thank you, Dr. Soni, for giving all of us the opportunity to see each other. I think I'm getting to see lovely Lakshmi, Dr. Manish, Raju. I think Raju we met long back in a conference. Of course,
yes.
Virtual is the best way to say hello to friends.
That is a gift of Corona to us,
Yes.
Meeting each other virtually is a gift of Corona to us. Everything negative, only this thing positive.
Thanks.
Thank you, ma'am.
Thank you, ma'am.
Thank you
and
so much.
I would like to thank Sweetie for bringing all of you together.
Ma'am, we want the protocol of freezing and thawing and how you're preparing.
Yes, I will probably put it on the group only. I will write up, because this is part of the thesis and now we are so used to it that her work has finished, but the PRP arm is going on. It's very simple, nothing. The centrifugation at what rates. In fact, I made this PPT for a PRP presentation and how we sort of do it. I'm repeating this in fusion, but because my topic is almost similar. And I would be happy to share. There's no fancy thing in it. It's simply the RPM is simple. The supernatant is taken and then it's put in -20. And we've had patients who we gave up to 3 PRPs. After 3, I don't make an effort. I'll again share after 3 it doesn't improve. And I've generally done 1 cycle before. But lately I realized that I even did it in the index cycle of FFT, but I just gave it before, while she's on the estrogen priming. Started giving her 1 PRP maybe on day 2 or day 3 and gave another by day 6, not beyond day 10. So everybody has, because the literature shared me that you could give up to 3 days before an FET. I didn't have the guts to prick the endometrium with the needle right. But the one whom I did, I could never reach a good line even. That's my experience. And I quit it. This is one of our doctors. So somehow, and she has no tuberculosis, no reason why. PCOS, of course, yes, her lining doesn't show. I know probably PCOS are also prone to giving you brilliant embryos, but yet probably there is some element of the testosterone levels which malfunction at the endometrium, and their endometriums are And I've never able to push her endometrium beyond 5.6, 5.7, and I don't have the guts to use her good embryos. So we'll wait.
Ma'am, in these patients in the
Watch
same
maybe
cycle,
something
when
may
you
show
are
up
doing the
later.
PRP, you are giving this with a needle, you said. I mean, it's not intrauterine?
Yes. No, so no, I don't believe in, I'll tell you my reason, because this Carlos Simon thing, and I will show you the genesis of this study. So while we were attending one of the SRMs in Philadelphia, I believe it was 2019, Carlos Simon, having published his paper in 2016, invited us for sending patients for pre-treatment, and this was his joint trial that is doing with the Harvard University. And when they had this trial going, the beauty was they could never get patients, and me and Dr. Firuza Parekh were the only people who jumped up to say we'll be sending patients, but he really backed out because we were talking about tuberculosis. But then when he talked about his whole presentation, he said if the stem cells have to be working, they have to be given right into the endometrium, below the endometrium, to be absorbed and picked up closer to the spiral arteries, which I showed you the human reproduction. So I thought to myself, and his thought was that if you just put it, because there's a lot of work on stem cell given intrauterine, and he said no, it will not be. And there was a similar presentation the same year in X-ray. So both the groups were embolizing, putting catheters through the femorals, going to the uterine arteries, in the hope of putting whatever stem cells, be it the bone marrow or PRPs, right at the level of this thing. So the thought generated in 2019 to me that if they are fearful that they will not last on the superficial layers and they need to good, I just thought, why don't I inject it under the endometrium? For me, the best thing is using a ovum pickup needle by Cook. So when I'm doing adhesiolysis in some of the patients where I feel as part of our trial, and they're not major, even sometimes we are doing the first sitting when they're major adhesions, I'd never waste the stem cells or PRPs. We probably come on the second sitting when the cavity volume after a 3D ultrasound has improved, the thickness, maybe whatever, and then we inject. What we do is we prepare the PRP or the stem cells. We take 1 ml and the same Cook's needle that you're using, the 17 gauge needle that you're using for ovum pickup, we push in 0.25, 0.25 mils into the anterior, posterior, and the two lateral walls. Simple. Yeah, I can just share you the video. It's so simple. I use a 1.9 millimeters Karl Storz office hysteroscope through the side channel, saline, and trust me, people say that it leaks out. It never. It goes. You have to have the knack to identify the holes that you see. So beyond the bevel, there are some holes that you see, and then some. There's a point beyond which the needle becomes smooth. I can show you on the videos. I presented in many places to show the procedure. So while the bevel pierces very smoothly, you go a few millimeters deeper at a point where you don't see those holes in your view on the hysteroscope, and you just push in the 0.25, stay there for a while, not even 20 seconds. You come out. I've never seen the leak of. Many people ask me, what you're putting will leak out and be washed. I said, the saline never washes because I've not given on the surface. I've gone nicely 3 to 4 millimeters, or for that matter, 5 millimeters deeper into the subendometrium. Why will it leak out? Why will it wash out? And again, the proof is the data. From the 50 patients, 32 have improved and 17 have been pregnant. I don't think I need, however, to, understand this. And when a lot of people questioned, I've given another thesis to an ex-candidate. And what I'm doing is I'm comparing the two arms, intrauterine versus subendometrial, to really know, because a lot of people say everybody may not have a hysteroscope in her vicinity and she may not have a 1.9, such a brilliant office. So says, let's try it. But this group of patients is now not thin endometrium. We are looking at RIF. He said, because, for ethically, they'll ask, you already tried it. Why are you experimenting in the same group? So to get our ethical clearances, because every time we can't repeat theses, we can't repeat the same story. So we moved from the story of, but these are not all RIF. These are all RIF with endometrium lesser than 7, because you have to justify. If there's an RIF with good endometrium, why will I push in? So that's the whole ideology. Because the previous study, when we got the ethics, it was endometrium lesser than 5 millimeters. So let's see.
Please do share the video and the protocols.
Thank you very much for the.
And for those who are coming in Fusion, I will definitely show you my videos also.
Thank you very much.
Thank you. Ma'am, kindly put hysteroscopy and laparoscopy pics also, ma'am, of tuberculosis. So we also will get.
Sure.
Thank you.
Thanks.
So over to Sini for vote of thanks. Sini, please.
Yeah, thank you everyone. This was a very wonderful discussion. Thank you, Nina Malhotra ma'am, because tuberculosis, this is a very confusing topic for many of them, many of us, even if no, the infertility specialist, because at some point of time there is always a confusion, as you have already discussed in this the vivid, clear discussions that we had, that just based on PCR positive, should we start a ATT prior to IVF? Which is the best time if you want to do an ultrasound to actually evaluate her endometrium, and how that we should depend on like peritoneal washings from POD and from the peritoneal washing. If they are TB PCR positive, then start the. So these are all so many confusions and doubts which many people have in their minds regarding when to start ATT, whether to start for all or not, based on findings, what are the findings. So many of these things have been made clear by you and very nicely shared by you. And all the experts have given their very valuable insights and time to come here and share their views. So I thank all the panelists, experts, as well as Nina Malhotra ma'am. And also I thank Anju Soni ma'am for this conducting this webinar so nicely. And today, like we have already completed 29th episode today, and we are hoping to continue this webinar series further.
Best wishes from our side, all of our side. Dr. Nina, best wishes to you.
Thank you, ma'am.
Bye-bye.
Bye. Thank you so much for inviting us. And it was really indeed a big learning
Well,
experience.